Well, thank you everyone for joining us for the first in this year's Ask the Expert. I'm really pleased to be joined today by Dr. David Liebovitz. Dr. Liebovitz is a co-director for the Institute of Augmented Intelligence in Medicine, the Center for Medical Education and Data Science and Digital Health. He also serves as the Associate Vice Chair for Clinical Informatics within the Department of Medicine and is an associate professor in internal medicine, preventive medicine, with an emphasis in biostatistics and informatics. And this is with the Feinberg School of Medicine at Northwestern University. The reason we've asked Dr. Liebovitz to join us today is he also serves as the chair of the Illinois Prescription Monitoring Program Advisory Board, as well as the chair of the Illinois Prescription Monitoring Program Peer Review Committee. And so with that, welcome, Dr. Liebovitz. We're very happy to have you join us today.
Yeah, thanks, Chris. Very happy to be here and um, share some thoughts on this really important initiative that we have for the state.
So the big question I think that our listeners have is the peer review committee can sound kind of, I think, scary to some prescribers. Would you be able to tell us a little bit about what this actually is?
Sure, sure. And so in general, peer review committees, when items are brought to their attention, they are reviewed to see if the pattern of clinical steps makes sense from a expert clinical standard of care perspective. So in general. And so the question sometimes is how do things come to the attention for peer review generically? And then within our specific context, we're looking from a very specific point of view. And the point of view here is in the prescription drug monitoring program, we're focused on um, identifying high-risk scenarios with use of dangerous medications, which can include opioid medications and can include benzodiazepine medications. But to actually surface things for this committee, we have the we have some challenges in terms of surfacing events for this committee, meaning that while the um, state of Illinois is able to receive updates from dispensing areas where controlled substances are given, what they don't receive as part of this dispensing information is the clinical context for
Sure.
why these substances are being prescribed. So the general duty is once things are identified, and the peer review, and we could talk more about that in a moment, peer review has set up different thresholds for identifying events that could then be brought. And there's more approaches that will come in the future. There's approaches that are being done now, but with an understanding that it's limited data to analyze to understand, well, maybe there's something going on here to look at. This can kind of set, the framework for how everyone should really view the peer review committee. The information that they have accessible is a very limited set. So there's going to be it has to be tuned to not be overly, sensitive where there's tons of false positives coming in, but you also don't want to miss things that you really should be able to find too. And then within that context, there's an information request that goes, and we could talk a little bit more about that. And then there's a determination from the committee because that information request provided that additional context.
Okay. Well, thank you very much. Wait, so in your opinion, as the chair of the PRC, what are some things that you find that the committee is looking at in terms of potential prescribing practices that are outside normal medical practice, or what we would consider to be outside of guideline-directed medical therapy?
Yes. So in general, if there, what we've tried to do is look for events that we know are high risk sorts of scenarios for adverse events to happen to patients. And adverse events, meaning having an overdose, passing away, needing medical attention, and what are the sorts of scenarios that can lead to that sort of thing. So if the same patient receives extremely high dose of opioids for an extended period, that's a concern.
Okay.
If the same patient receives opioids in combination with benzodiazepines, that can become a very high risk concern for respiratory impact from this.
Sure.
So within that context, at the moment, and we also have to realize that the peer review committee is a voluntary committee of members, and the members and we have a lot of prescribers in the state of Illinois, and for the lots of pain, unfortunately, that exists for patients, and opioids being important modalities for helping assess pain along not the only, but an important part of this, that there's lots of these prescriptions being sent. So it's been a challenge to come up with specific scenarios that have a reasonable balance of sensitivity, picking up the cases we're interested in, but specificity. So we're not bothering people with things that are just, routine sorts of practice. With that in mind, the current focus, limited in scope because there's risk areas that are not being addressed in this, is that focus on the combined use of opioid medications plus benzodiazepines for the same patient for a bit of an extended period of time. And that's what we're looking at to identify high-risk scenarios, co-prescribing opioids plus benzodiazepines, not just a one-time, but by a prescriber for the same patient over an extended period of time. And then looking at how many patients fall into that category. And if there's a lot of patients getting it for an extended period of time with that combination risk, that seems to be a high-risk scenario where additional context may be helpful to the peer review committee to understand what's going on.
Well, I think that's so thank you for that. I think that's a great segue into my next question for you is that context. And when you mention context, like is the context end of life or hospice care? How does the committee obtain that information? How do they obtain that context?
So what the committee does when there is a threshold reached that exceeds X number of patients for X period of time on these combinations, for example, a letter is sent requesting additional information. And there's several questions then that the prescribers are expected to respond to. And those questions in particular, I can share a little bit. It's an example first. Do we even understand what their prescribing role is accurately? And this is from there's a taxonomy when getting controlled substances prescribing privileges in the state of Illinois, as well as licensing to have your prescriber taxonomy listed. Are you a hospice physician? Are you an internal medicine or a family medicine physician? And in that context, a first question is just to understand that context. So that's one of the pieces, the perspective that the prescriber is coming from. And then understanding that, and with lots of work by the state, because this is not an easy query to even assemble or an easy data set to assemble. So with that understanding now, with multiple iterations, we feel fairly confident about how our numbers come out, that when we're identifying the X number of patients for X period of time on these combinations, that this is in fact the case, or at least that prescriber's unique prescribing number is being used for those prescriptions. So in that context, then, the next question that we ask is to provide a general clinical rationale for that prescriber's current opioid, benzodiazepine co-prescribing patterns that we see in the data. And this allows a prescriber to indicate, oh, I'm a hospice working in end-of-life care, or I've taken over a practice where this was the standard of care, and you can see these numbers are coming down. I've been working with patients to change what they've been getting over time, undertaking all the appropriate safety approaches. And related to that, another question that we ask to help provide that context is for the prescriber to describe which risk mitigation strategies are they using to employ and how frequently. So this requires them to understand that first, that this is a high-risk situation, which requires mitigation strategies based on this combination. And then based on that, what are the steps that they are providing? And then we look at that. And as a committee, we've kind of settled on several different things that we think are really important, including things like providing alternative, symptom relief measures, monitoring with urine drug testing, for example, making available reversal agents for patients if they're overdosed in some way, and making sure that it's tracked and that the prescription drug monitoring program is being accessed to understand which prescriptions patients are receiving. So those sorts of things that we're looking for, plus other kind of practice operational things to do this. And how often are those risk mitigation strategies used? This is important context for the peer review committee then to understand, because if you're taking care of these high risk patients for a group of them, it's not just one also, it's a group of them in a high risk combination prescribing of benzodiazepines and opioids scenario for an extended period of time, medically, this is recognized as a high-risk state. There should be some additional safeguards in place. And this is providing the opportunity to explain how the practice does it. Further additional context questions include things like, does the physician have a subspecialty also for which they're certified in or practicing within? And then specifically, how are they using the service that the state provides from the prescription drug monitoring panel?
So it actually sounds like the goal is patient safety at the end of the day. If you had one or two things that you could share with a prescriber that might receive one of these letters of information requests, what would be the salient points you'd want to share with them?
Yeah, first, to excuse me, reassure them that we don't have all the context and everything may be absolutely perfect. So they should have no concerns. This is an opportunity for them to engage proactively for a high risk population, or at least to share how they are managing a population that's high risk. And if it turns out, for example, that they haven't implemented some of the mitigation strategies, this is going to be an opportunity for additional educational resources to potentially be made available, at least directed to that user, to that prescriber, to have access to. So when someone gets this letter, they should realize this is kind of statistically generated. It's statistically generated based on trying to balance the reasons that I mentioned before, the sensitivity and specificity, to just say, okay, there's a group of patients who seems to be at high risk here, from a state of Illinois doing its due diligence for the citizens who live in the state. It's important to understand some of the context of their management, which we can't otherwise get. And we're not doing this for every patient, but we're doing it for scenarios in which a prescriber has a group of patients that fall into this category to understand it. So it's an opportunity to share the approach. And if for some reason a safety approach isn't there, this will be an opportunity to receive additional education in that. But it's important to be clear, realize that there are practicing clinicians on the peer review committee who understand all the hassles of current practice, the frustrations of current practice, the fact that systems don't always work well, and everything else. So we are really looking for good faith efforts to do right by a high risk set of patients. And it's really just explaining the approach there and engaging constructively, realizing it's colleagues on the other side of this, not a panel that's attempting to be tough on prescribers in the state of Illinois. It's looking for safety for the citizens and balancing that against the realities of clinical practice and understanding this context to put it together. So it's really pros come at it with that attitude after receiving a letter to just explain what's going on in the approach. And there should be a positive interaction in this, especially with the spirit that, there's additional resources potentially available and links and things that could be there from the prescription monitoring program site that could be helpful to patients and practices if they haven't used before. So hopefully it's not a one more thing to do is never,
Right.
great, but hopefully to look at it as this shouldn't be construed as that onerous, but and realize that they're colleagues on the other side of it.
Thank you. So it sounds like this shouldn't be construed as a gotcha, but more of an opportunity to enter a dialogue and potentially everybody come out with potentially safer practices.
Absolutely.
The education that is offered, that's the education that's offered by University of Illinois, correct?
Yeah, currently, although, pending future funding and future contracts, we may not be in such a nice position that we have been before. Whereas, for example, when the letter is received, one of the options that the committee may decide is to offer education or essentially to more or less, require education to be engaged with for the prescriber afterwards. And the satisfaction has been very high for the prescribers who have undergone education, whether it was opting in or being advised that they need to go through some education to help them, has been positive regardless of the category. And with that in mind, this service has been offered and hopefully will be able to be continued where the various risk mitigation strategies and alternative pain approaches are reviewed with prescribers in interactive Zoom-based sessions with the educational team from University of Illinois.
Okay, thank you. So, as somebody that's involved in reviewing the responses, so the peer review committee has sent a letter just asking for a little bit of additional information, doing the due diligence to protect the patients of the state. If you had some advice as somebody that reviews the information responses from prescribers, what kind of advice might you give?
Yeah, a couple things. One is think about it. Don't quickly jot something off very fast just to get it done. So it is worth, this is a high risk set of patients in one's, professional practice that have been identified. So, in the sense, based on prescribing patterns, we know there's a set that are in a high risk scenario. And just like a jet pilot may inspect the plane before getting on and flying, if one is managing a high risk group of patients, it is important to take it seriously because these patients are at risk of complications directly resulting from the care that we're providing and the prescriptions that we're writing. So in that context, take it seriously. So the first step from the response is don't just jot something off. Think about it a little bit before responding. And then when responding, realize that one is again communicating with colleagues who are not out to get you, but are instead just out to understand the context. So based on the questions that I alluded to earlier, it's kind of when responding, really think about those opportunities. And in fact, although we haven't seen this explicitly, what I would say is would be viewed favorably in letters such as this is, I've taken this opportunity to look at this information and at length because these are high risk scenarios. And I realize I'm doing some things, but I actually could do more. And I'm going to institute additional measures as follows in my practice to further risk mitigate. And so, in other words, to have some thought about this process. And I would predict our committee would actually respond favorably to a positive engagement in a fashion, recognizing that these are important scenarios. And by and large, the responses we get are positive engagement and describing this. There are occasional very quickly jotted responses that don't demonstrate really recognition that these patients are at high risk, or ones that clearly there wasn't very much thought put into the message, or it's being looked at from a very defensive posture, such that phrases and content there just doesn't make sense when reading through it. So, what I would say from this peer review committee, again, of colleagues just looking to understand the context and explain it, and even if this is now being brought to a prescriber's attention and they haven't done everything they could, but this is now saying, maybe I should do more. Here's the things I'm planning to do now, and this is where I'm going to go. It's highly likely the peer review committee is going to look very favorably on responses, anything that's engaging that way, again, to improve safety of the patients, which is the goal.
Well, thank you. And I mean, the name of the committee says it all. It is the peer review committee. So, well, thank you very much. I want to thank you for all your leadership and insight that you provide as the chair of both committees. I think that this is definitely an important effort in maintaining and improving the safety of patients in the state. And thank you very much for joining us today for this discussion.
Thanks. Thank you for the opportunity. Thanks.